Okay. You have 30 seconds to relax, stretch, and breathe, and make sure that you are fine. So I'd like to ask the following question is, how many people in this room have heard about sarcoidosis? And raise your hands. Okay, well, I'm surprised. Good. It's a good number. What I'm going to describe is our experience with clinical, pathological, and treatment issues related with neurosarcoidosis. One of the reasons we like to discuss about sarcoidosis is because sarcoidosis is a disease that is multisystemic, and when it affects the brain or spinal cord, mimics disorders like multiple sclerosis and transverse myelitis. And what we are trying to do in terms of medical interaction is to advise a lot of physicians that sarcoidosis is a disease that needs to be evaluated carefully before establishing a diagnosis of multiple sclerosis or transverse myelitis. So let me introduce the topic first. Sarcoidosis in general is a systemic disease, meaning that may affect different part of the body, different organs, but is mostly a disease that affects the lungs and affects the lymph nodes. And obviously, lymph nodes are intimately related with immunological function. At the present, we don't know exactly what is the cause of this disease, but what we know is a devastating disease in some patients that can produce a multitude of symptoms that are manifested like chronic coughing, a lot of fatigue, a lot of problems associated with pulmonary symptoms, and problems associated with weight loss and systemic symptomatology. Now, this disease is found frequently when physicians are evaluating X-rays of the chest and find that there is a lot of enlargement of lymph nodes in the lungs. And obviously, that leads to assessment of those lymph nodes, biopsies, and that is when there is demonstration of pathological findings that are the presence of granulomas, and that is basically the hallmark of the disease. Now, at the present, as I mentioned, there is no direct evidence of factors that produce sarcoidosis, but there is a lot of speculation that this disease may be an infectious disease that may be mediated by mycobacteria or may be mediated by microorganisms that are going to produce chronic infections that affect lymph nodes or the lungs. It's very well known that there is some type of genetic susceptibility. There are population studies already that have demonstrated that some major histocompatibility complex markers are associated with a high risk of this disorder or with a decreased risk of this disorder. It is known also that some of the cytokines genes, polymorphism in those cytokine genes may be involved in genetic susceptibility. In this area of the United States, in the southeast and northeast, there is a increased number of patients with sarcoidosis, and it's basically at the expense of African American population. So sarcoidosis appears to be more prevalent in patients with African American ancestors. However, it's also very well known that Caucasians from Nordic ancestors, people with that are descendant from Caucasians from northern countries, Sweden and Norway and all of those countries over there, they also have a high incidence and prevalence of this disorder. At this moment, we don't know exactly what is the reason this clustering of sarcoidosis in these populations. And that is raising some concerns about potential issues like environmental risk or presence of some familial clustering in the presence of sarcoidosis. Now, One thing that is interesting is there is already a very large longitudinal study on sarcoidosis that was done at the end of the 90s and was finished in the early 2000 that demonstrate that there is a cumulative risk of sarcoidosis in relative of patients that have suffered the disease. And interestingly, there is also a potential for some subset of sarcoidosis cases in parents of people that have been affected with this disorder. Now, in general, this is the population that may be at risk of neurological problems. It's not necessarily a high percentage of patients with neurosarcoidosis. In the study of ACCESS, that is the largest longitudinal study on sarcoidosis that has been done in the United States, it was found that approximately 4.6% of the overall population suffer some type of neurological involvement. However, the neurological involvement was very aggressive enough to produce a lot of disability because the presence of either a spinal cord involvement, peripheral nerve involvement, or encephalitis. Now, as you can see in this diagram, you can appreciate that sarcoidosis affects predominantly the respiratory system, but other areas of the body, including skin, including the eye, including the liver, and other organs of the body may be affected by this disease. And this is the reason we call this a systemic, a multisystemic disorder. The main peak of onset is between 30 and 50 years of age. And as you can see in this diagram, the black bar here is female population. The light gray is male population. At some point, there is a predominance of female population being affected by this disorder. These are some of the manifestations on the skin. Sarcoidosis may produce mucosal lesions, may produce skin lesions that appear to be chronic, and obviously that is going to be one of the keys in diagnosis of this disorder. One thing that is interesting again is despite the percentage of sarcoidosis being relatively low, around 5% of the population, it is very clear that the female population is more affected by neurosarcoidosis as compared with the male population. The reason this susceptibility is, again, unknown. And sarcoidosis may manifest acutely, mostly with skin manifestation, ocular manifestation, or may produce chronic symptomatology, and the chronic symptomatology may involve different organs. Now, what we do as a clinicians when we see patients with suspected sarcoidosis is to do a very thorough evaluation. And as I mentioned, since the main area of involvement are the lungs, we pay a lot of attention to the respiratory system, and there are different approaches, including chest CT scan, gallium scan, that are nuclear medicine testing, as well as FDG PET scan, also a nuclear medicine testing, that allow us to detect areas of inflammation or presence of enlarged lymph nodes. There are other approaches. The use of angiotensin converting enzyme is occasionally useful. I don't think that this is the only parameter that is available, but occasionally is of value. In the 60s and 70s, there was a test that was introduced by European physicians that was called the VAME, but this is no longer available because the potential risk of transferring infection. So it's no longer a test used in the United States. So in summary, approximately 5 to 10% of patients with sarcoidosis may present neurosarcoidosis. And the interesting part of this population is that there is a 50% of those patients in which the neurological manifestation is the first manifestation of the disorder. And this is the reason we always try to raise attention about this issue, because those patients are patients that may manifest with disorders that can mimic multiple sclerosis or mimic meningitis or mimic spinal cord involvement. Historically, there have been several studies that point out the multifocality of neurosarcoidosis in the central nervous system, meaning that sarcoidosis may involve presence of abnormalities in cranial nerves. Optic neuritis is one of them. Facial paralysis, another example of cranial neuropathy. Or it may be possible that the patient manifests with meningitis or manifests with other problems like hydrocephalus, hypothalamic dysfunction that is manifested by endocrinological problems, presence of myelitis, myelopathies, or presence of muscle involvement or peripheral nerve involvement. So the casuistics that have been published in the last 20 years basically demonstrate the multifocality of involvement of this disorder. From our point of view, we try to explain that sarcoidosis is a disease that may affect any compartment of the central nervous system or peripheral nervous system. And in that way, patients may have problems associated with encephalitis, may have problems associated with myelitis, may have problems associated with the cranial nerve involvement. Now, the evolution of this disorder is quite variable. There is a subset of patients in which the main manifestation of the disease is an acute manifestation, just one episode of either cranial nerve involvement or one episode of meningeal involvement, meningitis. But there are other patients in which the course of the disease follows a pattern that is very similar to other immunological disorders like multiple sclerosis. In that way, they present a temporal pattern that appear to be relapsing and remitting. And there are other group of patients in which there is a chronic progression of the disorder that obviously produce a lot of disability and neurological problems. In general, the most acute manifestation of the disease, as I mentioned before, is the presence of cranial nerve involvement like facial paralysis or bell paralysis or a form of acute meningitis. And the subacute and chronic forms, encephalitis or myelopathic forms are also frequent. So let me show you some of example of this disorder. Let's focus first on the meningeal manifestation. And again, the meningeal involvement associated with sarcoidosis implies that you may have patients in which there is a septic meningitis, meaning that there is a chronic inflammation or acute inflammation that is not associated with bacterial infection or viral infections. It's possible that these patients may manifest with chronic meningitis or recurrent meningitis, or in very aggressive forms may manifest with a thickening of the dura mater or even presence of tumor-like lesions of the dura mater that many times mimic brain tumors. And obviously, all of these manifestations, all of these inflammatory processes are going to produce a multitude of symptoms that go from presence of headache, presence of hydrocephalus, or even presence of other problems like cranial nerve paralysis and papilledema and visual loss. Now, this is an MRI just to demonstrate that meningeal involvement means inflammation of the covering of the brain. This is a brain MRI in which we are pointing out here that there is enhancement of the leptomeningeal. That is one of the manifestations of the disease. This is another example of that. I don't know if you are able to see very well these lines that are white lines here, or these areas in which there is a patchiness, an enhancement. That is just the manifestation of the inflammatory process affecting the meninges. Pathologically, this process is characterized by presence of inflammation that is going to produce infiltration by white cells in the meninges. and it's going to produce presence of granulomas that are the most important hallmark of this disorder. In the group of cranial neuropathies, these diseases or this form of manifestation are going to affect different cranial nerves, like the optic nerve, or may produce involvement of the facial nerve. And these manifestations may produce other symptoms that may involve visual loss, may involve muscle dysfunction, and are going to behave in different temporal patterns from acute manifestations to subacute or chronic manifestation. Now, in terms of meningeal involvement and cranial neuropathy, it's very frequent to see the association of the two disorders, because meningitis in general may produce an involvement of one portion of the brain, that is the brainstem, and in that way, that meningitis may get some cranial nerve involvement and obviously produce manifestations that are predominantly cranial nerve paralysis. Now, from pathological point of view, when a cranial nerve is affected, the major change is the inflammation, and you can see this is a cross-section of a facial nerve of one patient that died after sarcoidosis, and you can see this is the facial nerve, and this is the infiltration by inflammatory cells of that cranial nerve. Now, one of the most aggressive manifestations of these disorders are the encephalitic form of the disease. Encephalitic form means that there is inflammation of the brain parenchyma, and that is in contrast with other forms of the disease in which the inflammation is predominantly the covering of the brain or the meninges. Now, these forms are very aggressive because affects white matter or may affect the gray matter or may produce tumor-like lesions that are going to produce complex manifestations that include headaches, psychosis, seizure activities, endocrinological problems, and that is going to produce significant neurological disability. These are the forms that frequently mimic multiple sclerosis, and it's extremely important in patients that are being evaluated for multiple sclerosis to make sure that they don't have neurosarcoidosis. And the reason is the pattern of behavior of this disorder when affect the brain parenchyma is a relapsing remitting or a chronic profile, obviously very similar to what happened in multiple sclerosis. And these are very dramatic pictures of brain of patients affected by sarcoidosis. These are patients, this is one patient that we evaluated recently, in which there was an extensive change, extensive encephalitis affecting predominantly the white matter. Initially, there was concern about the presence of a brain tumor, like a glioblastoma multiforme, and that's the reason this patient got a biopsy. And the surprise for us was that this was not a tumor, this was not a typical encephalitis, this was a manifestation of sarcoidosis, because the biopsy demonstrated the presence of these granulomas and inflammatory reactions. And obviously, these are the hallmarks that define the disease. Now, in this particular case, for example, what defined and concluded the overall clinical assessment is that these patients suffer of neurosarcoidosis and encephalitic form, and this was really good news for the patient because we were able to treat the inflammation with use of IV solumedrol, that is a form of steroid, and subsequently the patient received treatment with prednisone, and the patient is doing much better. And obviously, doing the further investigation, we found that that patient had also sarcoidosis affecting her lungs. Now, probably many patients with transverse myelitis, one of the concerns, particularly when there is a subacute form of myelitis or a progressive myelopathy or chronic myelopathy, is the presence of sarcoidosis. And we see this with a relative frequency in patients with this type of temporal profiles. So that's one of the reasons, one of the issues in the differential diagnosis of myelopathy is evaluation of neurosarcoidosis. And neurosarcoidosis in the spinal cord is very aggressive. It produces a lot of spinal cord changes, and you can see here this MRI of a patient affected by neurosarcoidosis, and it's taking the disease, the inflammatory granulomatous change is taking a large portion of the spinal cord, and obviously this is going to produce significant clinical manifestations. Paraparesis, meaning weakness in the lower extremities, and also sensory deficit. This is another example. You can see the spinal cord. This is the longitudinal section in which you see the part of the thoracic and lumbar spinal cord, and these are the cross-section. This is the cross-section of the spinal cord, and in the middle, this is an area that appears bright white, and that is a manifestation of the inflammatory process in this disorder. Now, as I mentioned before, neurosarcoidosis may produce involvement of any compartment in the central nervous system, but it may affect also part of the peripheral nervous system. Two examples is may affect the peripheral nerve or may affect the muscle. And obviously, this is going to be associated with significant manifestations like presence of numbness, tingling, or presence of muscle weakness. Now, this is a very complex diagram, and when I put this here together, I say, okay, we need to split this. So this is what we see in terms of treatment. The treatment is divided in acute treatment or treatment of the acute manifestation or treatment of the relapsing, remitting, or chronic forms of the disease. This is the acute treatment. So the acute treatment is based mostly on the use of IV solumedrol or methylprednisolone or use of prednisone. And this is very similar to what we use in patients with acute myelitis or patients with flare-ups of multiple sclerosis. So in many terms, in general terms, the treatment of all of these immunological disorders is very similar in many ways. And however, when we finish the treatment of the acute manifestation, we need to decide if the patient needs chronic treatment or the treatment of the acute process was enough to control the disease. In the majority of patients with neurosarcoidosis, unfortunately, we need to go to chronic treatment. And the chronic treatment is based on the use of different medications that include use of immunomodulatory medication or use of immunosuppressant medication. In the case of immunosuppressant medications, we use medication that probably you are very familiar with them now, methotrexate, azatropine, cyclophosphamide, or mycophenolate, that is a CellCept. And all of these medications are helpful in the way they are going to control the inflammatory process that is one of the main mechanisms of the disease in neurosarcoidosis. There are recent treatment approaches. There is the introduction of new medications that modulate the presence of some cytokines. There are some medications like this one that produce modulation of the antibody response in sarcoidosis or the reduction of the TNF-associated production. So all of these immunosuppressant approaches are very helpful in the control of the symptomatology. Now, the treatment of sarcoidosis depends on the clinical manifestation and the temporal profile. And this is extremely important because there are encephalitic forms and myelopathic forms that requires more aggressive treatment, meaning not only use of steroids, but also use of immunosuppressant medications. There are forms of sarcoidosis, for example, acute forms, in which the use of steroids or use of prednisone is good enough to control the disease. Now, obviously, the temporal profile is extremely important. If we have a monofocal disease or we have a multifocal disease, that will decide what type of aggressive approach we are going to use. Now, I brought the issue of treatment in women or elderly people, and the reason is the majority of approaches imply the use of prednisone or chronic use of steroids. And this is obviously very difficult in women that are postmenopausal because the high risk of problems associated with osteopenia or osteoporosis. So that is one of the reasons we need to take a good approach and make sure that we don't produce more harm rather than benefit. Now, one specific issue I like to bring here is that in many patients, there is damage of the neuroendocrine function. And that damage is produced by involvement of one part of the brain that is called hypothalamus or pituitary gland. And in those particular situations, this is going to produce a very chronic endocrinological manifestation that requires the involvement and the treatment of endocrinological problems like hypothyroidism, hypogonadism, another complex endocrinological process. And obviously, this is not necessarily going to be associated with active inflammation, but just the consequence of the damage that those areas of the brain like hypothalamus or pituitary gland are going to experience during the process of damage. Now, I'd like to finish here with the following conclusion is sarcoidosis is a multisystemic disease. It's immunologically mediated. We don't know the etiology of the disorder, but we know in many ways that these appear to be a disorder that mimic a chronic infectious disorder that in many ways may be similar to what we see in tuberculosis, and that is one of the reasons what we are focusing now in the search of potential etiological factors like mycobacterial infections. Now, this is very heterogeneous, and one of the things that we emphasize to everybody is every patient with multiple sclerosis, every patient with myelitis or myelopathies need to be evaluated carefully for sarcoidosis because this disease may mimic anything in the brain or in the spinal cord or peripheral nervous system. And that is one of the reasons we are trying to expand the education about this disorder, and we are trying to get NIH and different group of physicians working in immunological problems to get more attention and to pay more attention to this multisystemic disease. Thank you. All right. The standard of care is just like that, but we are trying to say and modify that concept. Number one, there are very good studies now that demonstrate that CSF ACE level is useless. There was a study in the Mayo Clinic several years ago that was published as a letter that detailed that after extensive assessment of spinal fluid in patients with sarcoidosis, the test was not necessarily reliable, and there was no evidence of a good sensitivity or good specificity. So I think it's useless to request CSF ACE level. Chest X-ray may help, but unfortunately it's not good enough. So what we are trying to encourage physicians who are evaluating sarcoidosis is, number one, is request a chest CT scan with contrast, or much better, but unfortunately very expensive, either a gallium scan or much better, a FDG PET scan. The FDG is a fluorodeoxyglucose PET scan. It's a nuclear medicine-based test that allow us to do an assessment of inflammatory activity in different areas of the body. It's a very powerful technique. Unfortunately, it's very expensive, and the majority of insurance companies deny the use of these tests for assessment of sarcoidosis. The cost is close to $5,000 versus a chest CT scan that is, I believe, between $700 and $800. So at this moment, what we are trying to tell the insurance company is, listen, if we diagnose sarcoidosis early, we can save a lot of money because we will avoid too much complications with those patients. And investing $4,000 or $5,000 in the FDG PET scan is going to save money in the future. But not too many insurance companies buy that argument. Now, the other issue that is probably important when you are suspicious about sarcoidosis is if you have a clinical evidence of something going on in the brain and spinal cord, and you have a suspicious chest CT scan, just get your pulmonologist involved. Try to get a lymph node biopsy, because if you demonstrate in a lymph node biopsy or lung biopsy that there is sarcoidosis, that patient very likely is going to have neurosarcoidosis, okay? And in many ways, it's much better to do a very thorough assessment of that patient at that moment rather than go and give treatment and then forget about. And the problem is if you give treatment for a patient with a neurological problem with steroids or prednisone, you are going to treat either way sarcoidosis of MS, and you may miss the opportunity to establish the definite diagnosis. And there is no literature. We are doing that study right now. We believe that almost 50% of patients with neurosarcoidosis have oligoclonal bands and have increased IgG index. And unfortunately, I couldn't show you the pathological findings in our studies, but in our pathological findings, we have seen evidence of B-cell infiltration in the brain parenchyma or meninges, and I think that that's the reason we see oligoclonal bands and IgG index increase. So unfortunately, that spinal fluid assessment is not going to help us too much in establishing a definite diagnosis of neurosarcoidosis. But as I mentioned before, if you have a suspicious chest X-ray or chest CT scan, you may have the opportunity to do a lymph node biopsy or a bronchial lavage or lung biopsy and see if the diagnosis can be established in that way. It's the first manifestation, and it's the first clinical manifestation, but when you evaluate the patient, you may find sarcoidosis. Yeah.
So you feel like the chest CT should be part of the work for everybody?
I think that's approach. And that is absolutely required if the patient is an African-American patient. And you emphasize to the residents and everybody, if you have an African-American patient, you are obligated to get a chest CT scan for problems like optic neuritis, problems like uveitis, problems like leukoencephalitis, meningitis, or anything that resembles multiple sarcoidosis. They are useful, but they are useful if you have a lot of pulmonary involvement and you need to follow that patient. Yeah. And the other thing that I really appreciate the question, because one thing that we need to emphasize is the care of patients with sarcoidosis is multidisciplinary. We need to get the pulmonologists involved, we need to get the endocrinologists involved, because those patients are going to have a lot of problems related with those areas of medicine. Patients are going to have ophthalmological problems as well, or patients may have a lot of cardiomyopathies because sarcoidosis also affects the heart and produce difficult problems with cardiomyopathies. Sure. Thank you so much. Time for coffee.